Today we'll be discussing prostate cancer surgical management. This is going to be a case-driven presentation, but at the same time we'll make sure we cover a lot of introductory level stuff and basics. And my name is Christopher Moran. I'm a medical student. Okay, so again, this is a case-driven presentation, and our patient is a 65-year-old male with a history of BPH or benign prostatic hyperplasia who's presenting to established care with urology following referral from their primary care physician for elevated PSA levels. We're going to talk about what that is in a couple slides. Patient symptoms include weak urine stream. Other than that, completely asymptomatic. Past medical history includes hypertension, hyperlipidemia, and most notably obesity, on a few different meds, including a folate supplement. No other family or surgical history. Social, we have 2 cigars per week, a 20-pack year history of smoking, lives with his wife, and is sexually active. So as we can see here, the ROS, or review of systems, is completely benign, with the exception of the GU system, genitourinary, where we have a weak stream. Vitals are relatively normal and unremarkable. So on our physical exam, general, respiratory, GI, we have a pretty unremarkable exam. The GU exam is also normal penis, scrotum, circumcised, normal testicular exam. And on the rectal exam, this is where we get into the interesting stuff. So the prostate is smooth, symmetrical, no nodules, and the prostate is only about 40 grams. So for reference, this is actually not that big of a prostate. You can normally see larger prostates in a lot of older men. A typical prostate might be 30 to 35 grams. So this one is only just slightly enlarged. Normal rectal tone, no other masses or fissures. Okay, so now let's get into the PSA. So PSA is actually really interesting. PSA can be used as a biomarker for prostate cancer. But at the same time, it's important to understand that PSA in and of itself is not really a bad thing. PSA is, or prostate-specific antigen, is a protease that's normally secreted by prostate tissue. Specifically, it's secreted into the urethra in order to have liquefying effects on semen. So PSA, its job is to basically act on gel-forming proteins within the serum, degrade them, and allow semen to liquefy or become a little bit more liquidy. So in cases of prostate cancer, what happens is the prostate will, the cancer will locally grow, invade, and destroy prostate tissue. This disrupts normal basement membranes and basal cell layers of the prostate, and also disrupts normal capillaries. This will allow increased levels of PSA, or this will allow increased amounts of PSA to leak into the blood. So it's important to not get confused, because this is a point that confuses lots of people. Prostate cancer tissue does not produce more PSA than healthy prostate tissue. In fact, prostate cancer tissue on a per cellular basis will produce less PSA than normal prostate tissue. The reason why you see elevated PSA in the blood of patients with, or serum of patients with prostate cancer, is because of the cancer locally invading and destroying and disrupting prostate tissue, allowing more PSA to leak into the blood. It's important to realize that you can also see increases in PSA with benign prostatic hyperplasia, which is a benign enlargement of the prostate that's seen in many older men. And this again, in this case, in the case of BPH, the increases in PSA are actually due to the increase in shear cell numbers within the prostate. So it's a little bit different than prostate cancer. While interpreting serum PSA can be very tricky, there's a few different rules of thumb that you can kind of use to help you out. Number one is that a PSA greater than 10 is typically, in the serum, is typically alarming, and that warrants further investigation for prostate cancer, just because an absolute value of 10 is so much higher than what we consider the reference range of about 0 to 4. On the other hand, PSA values 4 to 10 can be a little bit more difficult to interpret, because within the range of 4 to 10, this can either be due to benign prostatic enlargement from hyperplasia, or it can also be due to cancer. At the same time, in rare instances, you can see prostate cancer with perfectly normal PSA. So obviously the screening, the use of PSA as a screening test is not perfect. but there's a few different rules of thumb that we can kind of use to help us out. Another thing that's important to note in this particular patient's PSA levels is that we see that his PSA was relatively stable. You know, we have 2018, 2019, 2020, we're floating around 7. But then all of a sudden in 2022, we see that it increased by 5 to 13.7. So not only is that value just very large by itself, but we're also seeing an abrupt increase in PSA within a relatively short period of time. So this absolutely high value combined with an abrupt or fast increase is what we would consider very concerning for prostate cancer. And that's why they chose to work them up further for that. Okay, so feel free to pause the video and think of some differentials for increased PSA. All right, now I'll give you the answers. Okay, one, of course, is prostate cancer. We discussed why you see increased levels of serum PSA with prostate cancer. Benign prostatic hyperplasia, of course, that's probably the most common cause of increases in PSA. Another one is prostatitis. So this is inflammation of the prostate gland or organ. Specifically, it can typically be caused by bacterial infection. In younger men, prostatitis can be caused by sexually transmitted infections like chlamydia or gonorrhea, whereas in older men, prostatitis can be caused by, think UTI pathogens, things like E. coli. Of course, if you have something that's causing the prostate tissue to become inflamed, this will cause increased capillary permeability and damage, leading to increased levels of PSA seeping into the blood. This is why you can see increased PSA with prostatitis. Another interesting kind of little clinical correlate is certain activities like really rough, rigorous exercise or bike riding or even anal sex could actually also increase PSA transiently. This is because all those activities can cause local irritation and microtrauma to the prostate, resulting in disrupted basal layers and capillary beds that can increase permeability and allow increased levels of PSA to seep into the blood. So those are all activities that can also result in transiently increased levels of PSA, but it's usually typically not that much. Let me just fix this. Okay, and the last thing, lymphoma or metastatic disease. Of course, if you have a cancer that's traveled to somewhere else and it disrupts the architecture of the prostate, that can cause increased PSA. On the other hand, there's other cancers that are also linked with producing PSA, although these are somewhat rare and less specific. All right, so here's a nice little checkpoint question. So which of the following is the most important risk factors for this particular patient developing prostate cancer? You might have to rewind for this, but a lot of you, if you're familiar, you might not need to. The number one biggest risk factor for prostate cancer is considered to be age, and I put the main idea in red here. The main idea is that prostate cancer is one of the strongest relationships between age and any human malignancy. Very interesting. It rarely occurs before age 40, but incidence will rapidly rising and peak, typically around 65 and 74 years. And we can see in this graph here, this is a really fascinating graph, right? We can see basically from the ages of 0 to almost 40 that the incidence of prostate cancer is pretty much 0. And then once you start getting old and hitting those twilight years, that's when the incidence of prostate cancer will suddenly literally skyrocket, right? And that's why prostate cancer is pretty much the most common cancer that you see in men, in the West anyway. Interestingly, all of these other things that I listed here also have either protective or are considered risk factors for prostate cancer. Obesity is something that has been linked with prostate cancer. It's particularly diets that are very high in fatty foods. And there's a lot of research that has gone into this, although it's generally accepted that the link between prostate cancer and obesity is definitely not as strong as the link between prostate cancer and age. However, some blame obesity and diets high in fatty foods for being the culprit for increased prostate cancer incidence here in America compared to those in other countries. As a matter of fact, many studies have even looked at immigrants who come from other places like, let's say, Asia or Africa, and they immigrate here. and then once they're here, they have increased incidence of prostate cancer compared to their other family members that they have at home, which basically kind of nullifies any genetic effect that could have been maybe causing this. And that's why a lot of people say that it's a dietary or cultural kind of issue. Smoking is another thing that's linked with prostate cancer, although the link between smoking and prostate cancer is much weaker than the link that we see in other cancers, for instance, lung and pancreatic, where smoking is heavily linked with those cancers. In the case of prostate cancer, smoking is only weakly linked. Sexual activity is actually considered protective of prostate cancer, and there's several studies that have kind of looked at this. One study that I really like to reference is a study that was done by Dr. Jennifer Ryder and her team. I think it was back in 2016, published in the European Urology Journal. And then this was a study that showed that increased levels of sexual activity and or ejaculation have been linked with decreased incidence of prostate cancer. And there's a couple different hypotheses for why this relationship exists, but I think the easiest one to understand is probably the prostate stagnation hypothesis. And this hypothesis essentially postulates that over time, carcinogens will just naturally accumulate within the prostate. And by ejaculating more and, of course, stimulating increased activity of the prostate to produce prostatic fluid and various enzymes and secrete more of that into the semen, by increasing this activity, you are flushing out normal carcinogens that might accumulate in the prostate. So that's why this prostate stagnation hypothesis was kind of made, to kind of explain the relationship between sexual activity and prostate cancer. Past medical history of BPH is actually not considered a risk factor for prostate cancer. That's why it's called benign prostatic hyperplasia, because it's benign. So people with BPH typically are at the same risk of getting prostate cancer as people who don't have BPH, adjusted for age and other factors, of course. Folate supplementation is also another very interesting one. Folate supplementation and higher levels of folate in the blood have also been weakly linked to increased incidence in prostate cancer, although very few clinicians actually consider this link to be serious, and most would consider folate supplementation as a whole to be benign. The research is actually rather shoddy in that area. All right, and this is another good question. Which of the following is the best next step leading to this patient's most likely diagnosis? Feel free to pause the video and kind of review if you need to, and I'll reveal the answer is prostate needle biopsy. So the main idea here to know is that prostate biopsy is a critical step for diagnosis, risk stratification, and the ultimate determination of the steps that you use to treat and manage prostate cancer. And that's based on what the AUA recommends, based on their plethora of laboratory and clinical research that they reviewed. So the prostate needle biopsy is critical for determining the next step and staging prostate cancer. In terms of how you get the prostate biopsy, there's actually a very nice image here. Typically it's image guided, so you'll use something like an MRI, or in this case they're using ultrasound. And remember, the prostate can be found directly anterior to the rectum, right? So it's not hard to imagine that you can stick a probe into the rectum. You can use this probe to shoot ultrasound waves and visualize the prostate, and then you can stick a needle into the perineum, and you can use this needle to pull out little tiny samples of prostate tissue. Typically they call these cores of prostate tissue. And what they'll do is they typically like to bisect about 12 different areas within the prostate, so then they'll pull out 12 different cores. What they do is they then send these samples to a pathologist, and the pathologist can then further analyze these samples under the microscope. Other things that you might want to get include a urinalysis, a chest x-ray, so this will allow you to check for any METs or any other abnormalities. CBC, BMP, and EKG as well can also be helpful. All right, so I really like this slide. Prostate biopsy, the most confusing system ever. So the system that we use to categorize prostate biopsy specimens is called the Gleason score. And there's a really nice image that I got from AMBOSS, very great program, highly recommend medical students to look into getting AMBOSS. I reference them all the time. This is a really nice image from AMBOSS that kind of summarizes what the Gleason score is, right? So the whole idea here is that pathological patterns can be graded numerically based on severity or how bad the cancer is, so to speak. So lower Gleason pattern is typically more benign, whereas a higher Gleason pattern is characterized by no recognizable glands and sheets of hyperproliferative cells that we usually associate with prostate cancer. And what they do is, remember, these specimens are actually pretty big, relatively speaking, if we're kind of interpreting from the context of what you can look at under a microscope. And of course, in different areas of these specimens, the pattern can look somewhat different. So the way they score each specimen is by adding up the first and second most common patterns that you see within that specimen. So for instance, if you see 2 5s, so that would be the first and second most common pattern within the specimen is both Gleason pattern 5. Then your Gleason score would be a 10, and that would be considered a more aggressive kind of cancer or specimen. Whereas on the other hand, if you have Gleason patterns 1 to 3, right? So let's say you have something like 2 3s within a specimen, that would be a 6, and then that would be a typically more benign specimen is what we would consider that to be. The Gleason grade group, and I love how they make them all sound so similar, the Gleason grade group is what we use for risk stratification, right? And we can see this here, how based on the Gleason score, you can categorize them into different Gleason grade groups. So a Gleason grade group of 5 would be considered more severe, and that comes from a Gleason score of 9 to 10. Whereas, something like a 2 would be considered a little less severe, and that would have a better prognosis, and that would be associated with something like Gleason 7. So the reason why the Gleason grade group and the Gleason scoring system can be so useful is because it can not only directly impact what kind of treatment course that you choose, but it can also affect your estimate of the patient's prognosis. So this is a really nice chart here, again from AMBOSS, that shows how as your Gleason score and your Gleason grade group increases or becomes more severe, the survival rate will also decrease. As you can see here, those with a Gleason grade group of 5, that's the most severe grade group, have a 26% 5-year survival rate, whereas those with a grade group of 1 have a 96% survival rate. So in this particular patient, so back to our case again, this patient had 5 benign specimens, 1 with atypical hyperplasia, and 6 with adenocarcinoma, with Gleason scores ranging from 6 to 9 in all of those specimens. And basically they went through a very complex algorithm, which we'll not get into, but there are algorithms that you can follow in order to risk stratify patients based on their biopsy results, their grade group, and various other demographic and PSA levels and all these other factors. They can use them to risk stratify them as a moderate versus high risk groups. And then this particular patient is considered to be an intermediate to high risk. And risk stratification, I want to emphasize, is extremely controversial and complex, and it's kind of beyond the scope of this presentation. So next steps for this patient with intermediate to high risk prostate cancer will include a CT abdomen and pelvis with IV contrast. And in this case, it showed an enlarged prostate with heterogeneous attenuation, and also prominent left para-aortic lymph nodes in indeterminate inflammatory etiology versus metastatic involvement. In other words, with the CT abdomen and pelvis, what you're looking for is signs of cancer that has moved, signs that the prostate cancer has also moved to other locations. That's called metastasis. It also helps the surgeon with planning out their operative approach, because the CT abdomen and pelvis can be used to review the patient's anatomy as well. A radionucleotide whole body bone scan showed no evidence of osseous metastasis, so those are bone mets or bone cancer that has come from the prostate cancer. And the patient was scheduled for radical prostatectomy with lymph node dissection. So now we're getting into our review questions. Feel free to pause these and kind of take a stab at them yourself. Number one, which of the following is the most common site of distant metastasis for prostate cancer? This comes up on med student exams all the time. It's one that you don't want to miss. The answer here is going to be the lumbar spine. The other one, which of the following is the most common site of distant metastases for prostate cancer? And this reviews the lymph nodes instead. In this case, the answer is the external iliac lymph nodes. So the main idea that I was trying to hit home with these questions is that evaluation of metastasis can guide staging and treatment. The iliac and obturator lymph nodes can be easily removed during radical prostatectomy. And I put easily in quotes because while you're kind of in the same area while you're doing the prostatectomy and it's realistic to dissect out those lymph nodes, it's still very scary when you see lymph nodes that are near big arteries like the iliac arteries and trying to like carve those out. That can be a very stressful process, and that's why only very skilled surgeons typically try to do this procedure. But it's great to get those lymph nodes because since the prostate cancer will lymphatically drain, typically we can see it here, so the prostate will typically drain into the internal iliac lymph nodes, and there's also some lymphatic drainage that's not shown into this chart where it goes into the external iliac lymph nodes. But since due to this lymphatic drainage, it's important that we evaluate these lymph nodes for metastasis, because if we excise the prostate but we don't remove these lymph nodes, that can put the patient in pretty bad shape. Alrighty, so this is going to be an overview of the actual surgical procedure for radical prostatectomy. And forgive me if I oversimplify things, but I really like the way that I typically explain this. So if you're doing a radical prostatectomy, everything in this red box has to go. So this would include the prostate, the seminal vesicles, the vas deferens, the prostatic urethra. And a question that people commonly have is, why can't we just carve out the prostate, and leave the urethra and everything else? And the answer to why we can't do that is kind of twofold. Number one is, well, the obvious thing, that's probably harder than just cutting everything else out. It would take, the prostate will be tightly adhered to the urethra in many cases, right? And it would be a surgical challenge to actually just carve out the cancer and leave everything else. But at the same time, you want to be careful, right? Remember that you don't really need any of these things to survive. The seminal vesicles, the prostate, the vas deferens, none of them are directly necessary for human survival. And prostate cancer, it's feasible for it to spread into any of these structures. And you want to make sure that if you're doing this big procedure and you're treating the patient with a radical prostatectomy, you want to make sure you're getting all the cancer out that you possibly could. So you're going to remove all these structures that are at risk for being affected by the cancer. So that's why you want to take out all of these structures. So after you're a couple hours into the procedure, it's going to look like this. So you've removed the seminal vesicles, part of the vas deferens, you've removed the prostate and the prostatic urethra. And at this point, you kind of have a urethra that's distal, and then a bladder neck that's more proximal. And then what you want to do, is you want to re-anastomose the urethra to the bladder neck. And this part of the procedure is actually always really fun. You literally just suture the urethra to the bladder neck. It's actually pretty wild. Re-anastomose is a fancy word for connect. All right, so next question. A patient who previously underwent laparoscopic radical prostatectomy with lymph node dissection presents to the clinic with erectile dysfunction for 6 months. Ooh, this is a good one. Which of the following was the most likely damage during this procedure? Feel free to pause. The answer is going to be the cavernous nerves, right? So the cavernous nerves are nerves that can be found within the neurovascular bundle that basically is found behind, so posterior and also lateral to the prostate. It's labeled NVB, neurovascular bundle, right? The cavernous nerves are nerves that are found within the neurovascular bundle that are basically very important nerves for mediating the erectile response. In other words, if cavernous nerves are damaged, this can result in erectile dysfunction. And erectile dysfunction is considered to be one of the most feared complications of radical prostatectomy by many men, because typically this erectile dysfunction is not reversible. So cavernous nerves, that's a nerve that used to be commonly damaged after prostate surgery. Luckily now, with the advent of new robotic-assisted and advanced surgical approaches, damage to the cavernous nerves is actually relatively rare when you're doing a radical prostatectomy. However, it still happens sometimes, even in surgeries that are perfectly done, and we don't know why. But luckily, we do have good treatment for erectile dysfunction if that does happen. So what you can see here, this is a penile prosthesis, or some people call this penile penis pumps, right? And what you do is you literally surgically insert a tube that can fill with saline into the penis. And then what happens is when the patient wants to have an erection and have sex, what they can do is they can inflate the tube, and then they have a reservoir that's implanted up here above the bladder containing the saline. They use this pump that's usually within their scrotum. They pump it up, and then this will cause the saline to drain into the tube and inflate the tube, and then this will stretch out the penis. The only issue that men typically have with this is that they lose some of their penile length. So in other words, the length of the inflated penis can only reach the it can basically only reach the length of the stretched penis. And typically, a fully naturally erect penis will be about 10 to 20% longer than a flaccidly stretched penis. So men that get these procedures will typically lose a little bit of length, but most argue that it's better to have this than to have no function at all. So typically, orgasm is perfectly intact with these prostheses, and the ability to orgasm is not lost, just the ability to get an erection naturally is lost. Okay, so kind of results wrapping up our case. So the pathology found extracapsular invasion of the seminal vesicles, which is one of the reasons why you want to get those out. So that's good, those were taken out with the surgery. No lymph node involvement was found, which is great because that would kind of lower the chance that there would have been distant metastasis. The patient regained almost complete urinary continence within 1 week post-op, which is awesome. The patient maintained normal erectile function post-op as well. Next steps include monitor PSA for downtrend in the future. So after you do this procedure, since the prostate is gone, you would expect that PSA would over time decrease. However, if you left some cancer within the body somewhere, or the cancer spread distally to other sites of the body that you did not remove, the PSA might continue to go up, or it can maintain at the same level. Either way, it won't decrease to the level that you would normally expect if you were successful. The patient would next want to be instructed on Kegel exercises in order to help them maintain continence post-op and increase the strength of their pelvic muscles. And the patient will also undergo might undergo adjuvant radiotherapy in the future. So some patients, after they get a radical prostatectomy, will also undergo radiotherapy in order to help kill whatever cancer might have been left. And that kind of concludes this presentation. So thanks for watching. I hope you learned something about the surgical management of prostate cancer.